All right, I'd like to thank GT Medical for the opportunity today and attendees who are watching this webinar. I think we have a nice little session that we're going to talk about a recent paper that came out from MCI, basically talking about surgical targeted radiation therapy versus SRS. It's a dosimetric comparison for brain metastases in the recurrent setting, which I think is important because this is a very different patient population to take care of. This sparked my interest as a past president of the American Brachytherapy Society. I've been doing a lot of interesting work in radiation, especially with brachytherapy, but isotopes in general. When we talk about GammaTile tonight, this is an isotope using cesium-131 with a relatively short half-life of about 9.4 days, and they're putting this in a tile, basically, in collagen, which basically keeps the hot spot off the brain. As we'll talk about tonight, a lot of what we used to do with brain brachytherapy involved iodine-125, but we just never really get our dosimetry perfect. But there are new vehicles, and GammaTile being one, which we'll discuss tonight, which I think solves some of the early issues we had with performing a technology or a technique, which was very beneficial to our patients of local control, which sometimes will manifest in patients living longer, or just as importantly, making it to a life event. Obviously, those of us who do work in the CNS setting, months and weeks matter. It could be the difference between making it to your child's graduation or not. And so I say it all the time, but like it or not, we all become patients, and whatever we can do for our patient population, I think there's a lot of valor and a lot of honor in doing such. And so we have three wonderful speakers tonight who are involved with the paper. Ranjini Tolakanahalli is a medical physicist at Miami Cancer Institute. She's the senior author of this paper, so I'm going to have her take us through quite a bit of the nuance of the dosimetric assessments. And the interesting thing with this, the dosimetric assessments of GammaTile, it's in comparison to the state-of-the-art of radiation oncology nowadays. Gamma knife, cyber knife, intensely modulated proton therapy. It really doesn't get much better than that. So I think as we go through tonight, we'll sort of see some of the advantages and the potentials that we might see become further in the armamentarium of what we can do for our patients. We're also honored to have Dr. Michael McDermott, neurosurgeon, with us today. He's the Chief Medical Executive at Baptist Health Miami, the Neuroscience Institute, and the IRMA, and Camille Best Endowed Chair in Clinical Neuroscience. He's also a co-author of this paper, so I do think he's going to have a lot of insights, especially being the gentleman who has been placing a lot of the GammaTiles for patients and knowing some of the past of how we used to do things and how we've evolved to where we're doing things now. And also today we have Daniel Kim. He's a radiation oncologist at Inova Health, and he's been using GammaTile as well and has some experience. And we'll provide another radiation oncology perspective, sort of like myself as a radiation oncologist up at Dana-Farber Brigham. We've been watching and tracking these technologies, and hopefully we can start to bring them to more and more patients. I think it's important to mention about 1,500 individuals have been treated with GammaTile since 2019. FDA approval came in 2018 for the recurrent setting, and then 2020, the FDA approval came to use this in the Novo setting as well. Lots of randomized trials going on, lots of excitement. A lot of things are going to change, I do think, in the future on how we do approach brain mets, and I believe GammaTile is going to play a large role as we move forward. But with that said, we're going to focus a little bit on today's paper. So, Ranjini, I would love to sort of start this session off and just ask, what inspired this study? And maybe you can help me kind of highlight some of the key findings that you found in this paper.
Oh, thank you, Dr. Orio. So when we started off with our GammaTile program over here, and we accumulated a bunch of patients, we know that in a postoperative setting, whether it is through the SRS or the SRT setting, the dose distribution can look quite different. And here we're talking about the implants on GammaTile with the seeds versus what we do see on an external beam modality. And the way we approach it is so different. From a physics perspective, the question did arise, how do we actually compare these two modalities, apples and oranges, and actually come up with some kind of credible comparative metrics where we can see what the dose looks like. So that was the idea behind this comparison, and to actually design this in such a way that we can actually compare clinically relevant metrics in how we perform these two different types of treatments.
Excellent. And so it is interesting because obviously GammaTile was utilized in this patient population. And then basically you were taking sort of the preoperative images and postoperative images and then determining how other modalities of treatment would show a similar effect. Basically looking, I guess, for conformality indexes, how much surface dose one would achieve. But more importantly, could we spare normal parenchyma, normal brain tissue? Can you tell me
Absolutely.
a little bit about that and sort of what the findings were?
Yeah, so, during the initial literature survey that I performed, I mean, when you look at some comparison of IORT with SRT, mostly what I had noticed is the comparison of, if you were to plan the resection cavity, how does the dose distribution compare? And you can look at the biological equivalent dose in order to make a fair assessment of what the normal brain tissue and GammaTile or LDR brachytherapy dose distribution looks like. But the main difference in the study in how we perform this is to actually look at the post-implant MRIs, like you mentioned, and use that to delineate the gross tumor volume and the clinical target volume as we would define for an external beam modality, where you're not looking at just the cavity, but the rim enhancement around that on the T1 MRI images. And so the very basic definition of how you would define a CTB changed between the two modalities, which triggered off the next steps on planning with the state-of-the-art external beam modalities and comparing that to the post-implant dosimetry that we had noticed or we have calculated on these patients that we treated here.
Yeah, I think what we saw was, GammaTile did just as well, if not better in some respects in terms of less, dose of some of the brain parenchyma and good surface dosing to where the tumor cavity would be. Mike, can I ask you, I know you have experience, we were talking a little bit offline in the past, I think we both started off many years ago in using iodine 125, and we've sort of evolved into the GammaTile using cesium. Can you give me maybe just a little bit of sort of a history of what was happening, how we sort of got here today, and maybe how GammaTile, you can explain maybe how GammaTile is a little bit different than we're using iodine and trying to sew it in with Vicryl or gamma foam and gliafoam and things like that.
Yeah, well, I started using iodine brachytherapy in 1992. I used iodine all the way up to 2017 until we made the switch to cesium. Went through the initial period of high activity temporary implants with the high activity iodine for recurrent malignant gliomas and also for recurrent metastases. The recurrent glioma and primary glioma thing didn't work out for toxicity reasons largely. And then the advances in chemo that it appeared that our time to tumor recurrence was actually longer with re-op and chemo than it was for brachy. So we kind of shifted away from glioma work and focused more on brain metastases, which are the most common brain tumor. And we also had a big interest and reported 25-year experience with recurrent atypical malignant meningiomas with good local control. After the high activity temporary implants, we used permanent I-125 implants. And we use those either singly, inserting them directly end on into the resection cavity wall, or using them when they were embedded in Vicryl suture and then laying them out in strings over the patient's resection cavity or brain surface. It's interesting that the very first brachytherapy case I did in practice was a recurrent malignant meningioma of the frontal convexity. And that patient, as far as I know, when I left UCSF, was still alive after brachytherapy, suffered from some radiation necrosis, but has, lived 25 years after standard treatment, surgery, radiation therapy, then had recurrence, then re-opt. So I was a big believer in brachytherapy. I still have my fingers for all the surgeons that are interested using appropriate radiation protection with the iodine, and I still use the same protection for the cesium. Radiation safety won't let us get away with not using anything for even the cesium. But in 2017, we published a paper comparing the dose to surrounding brain in a resection cavity model, I-125 versus cesium, and that's what we were talking about just before this recording. And there was a dramatic difference. So I said, okay, we're switching immediately. We're not using iodine anymore. And that was because the dose to the surrounding brain and volume was so much lower with the cesium for a number of reasons. So, I mean, I think point sources of radiation therapy have great conformity because the dose drops off with the square of the distance from the source. So it's always going to be nice and conformal to the resection cavity. I think there's a few things to be worked out, like for large mets that are symptomatic, do you really have to do pre-operative radiosurgery, or can you just operate and do the brachytherapy implant and use that as a single treatment session? Because we don't know. We know that pre-surgical radiosurgery reduces the leptomeningeal spread rate, but we don't know those results in a controlled prospective fashion with brachytherapy. And I think it's a great treatment. I mean, I've been doing it for a long time. So if I didn't believe in it, I wouldn't be doing it.
Yeah, no, I do believe, I think the company in the Roach trial is going to be trying to answer that exact question, right? If, basically going ahead with surgery plus GammaTile or surgery plus SRS, but where it goes. It's interesting. I got two drivers and one pending. We do a lot of drivers ed around this house because we're trying to put all these homely kids on the road. So be careful if you come up to Massachusetts and Boston in particular. But I always think, speed kills. That's what I keep hearing. Speed kills, and that's what I'm teaching the kid. But speed kills tumors too, right? Because with radiation oncology, tumors repopulate. And if the tumor repopulates and it takes 4 weeks to get someone on beam, that's a problem. So I like to, maybe it's speed kills tumors. Try to damage those cells when you can, because it does. There's a lot of repopulation as a radiation oncologist know, and Dr. Kim knows very well. That we wait too long, things start to grow back, and we don't get these great, good controls. So I think, there's some benefit there too. So I don't know, my daughter just walked by as we were chatting with her little driver's ed book. So I just thought I would throw that out there. But I think speed kills tumors, and I think we need to pay attention to that. Hey, Dan, just sort of thinking from a radiation oncology perspective, who do you sort of seek out? Who do you think benefits the most from the sort of start, the surgically targeted radiation therapy, or GammaTile with cesium versus say SRS?
Yeah, no, it's a great question. First, I'd like to just piggyback on Dr. McDermott's earlier comment around the cesium and iodine 125, because having had some experience with the stranded loose seeds, I think it's been clear based on a number of studies that the cesium 131 exposes lower volume of brain tissue to radiation, more uniform dosing to the CTV, and targets the desired CTV volume more accurately. And to your point, Dr. Orio, about speed, is, most of the dose is deposited in the first month, right? So there's some physical advantages with the shorter half-life. And one thing that people don't fully appreciate is the cavity dynamics for these resected brain mets, right? That Dr. McDermott and some of his colleagues are resecting. And so with minimal cavity shrinkage, more compact dose distribution, it clearly provides dosimetric superiority to something like iodine 125. In terms of patient selection for surgically targeted radiation or GammaTile, I think the clear benefit is in recurrent tumors, particularly patients who have had prior radiation. And typically we're talking about patients that have had prior external beam radiation, whether it's stereotactic based or IMRT or IMPT based. And I think that's where we see a lot of bang for our buck, so to speak. I think the data that has been shown, and more data has been coming out around this, around the dosimetric superiority, is just less radionecrosis, which is huge. As we know, that's one of the biggest problems that we face treating recurrent CNS tumors is radionecrosis. It's difficult to diagnose, it's difficult to treat. And the advantages of using GammaTile is not only do you get histopathologic confirmation with surgery, but you also get very targeted radiation to the cavity with rapid dose fall off.
Yeah, no, I like that, because I think we do have a lot of metrics when we look at the dosimetry, and Ranjini could probably, speak to this, but we have, sort of volumes of brain parenchyma which can receive 24 gray, 3 gray fractions, things like that. And we know that that's correlated with the radionecrosis. And if we can do things which can stay with those and within those parameters, but radiation is no free lunch. Dose has to go someplace. So if you can control your dose, I think, there's a lot of value to it. And that's, I think, where brachytherapy, which is obviously near and dear to my heart, comes into play, because you have these quick fall offs. You put the radiation where you want it. You don't have to transverse through the person to get the radiation to that area. You're putting it directly where the tumor is. I think, to your point, there's a lot there. So, Ranjini, speaking of that, were there any surprises with the dosimetric comparisons that came from the study, things that you might not have, sort of thought would happen, or, would you maybe provide some insights as you were going through, and things that maybe made you raise your eyebrows or feel, confident using different products or different techniques?
Yeah. So, when I started looking at the GammaTile, my expectation was that at 5 millimeters, we prescribed a 60 gray. If you compare this with the external beam, of course, I thought, well, you're going to have a better coverage and a sharp dose fall off. But as we went through all of these patients and, drew our clinical target volumes with the expansion that comes with it, with the PTV margin, and then looked at the actual dose comparison in terms of the BED dose, which is quite different between external beam and a GammaTile, the way we would compute the BED doses. The surprising thing was that after about 3 millimeters from the resection cavity, the GammaTile doses were comparable to that of Gamma Knife, and had a very sharp fall off, while it was higher for both CyberKnife and the IMPT doses. And at the surface, GammaTile delivered higher doses, and that did not come as a surprise. That's something that we did expect, right? Because of the way it's planned and the way the seeds deliver it. But after 4 millimeters, the sharp dose fall off is something that was not expected as compared to the external beam modalities. And the mean dose to the brain that we looked at, or the V24 gray that we were looking at for GammaTile, was significantly much lower. We expected it to be lower, but definitely this was much lower. So we're looking at 1.1 cc's as compared to 16 cc's for on an average with the external beam modalities.
That's interesting. And what would you say the depth of penetration is? Because obviously we want to make sure that, we're assuming a lot of these tumors is, completely resected. And I think Mike could speak that sometimes some cells are going to be left behind, right? And, some tumors are more invasive than others. So with this technology, it seems like we're prescribing to about 5 millimeters and getting our dose out that way. Is that a fair assumption, or what were you seeing in the study?
Yeah. So, although we expect that these seeds should be perfectly placed, there'll not be any rotation. Orientation will be exactly as planned, and we are expecting 5 millimeter dose to 5 millimeters of physical 60 gray. Ideally, that might not all the time happen. We have irregular shapes. We have tumors where the seed placement can come closer, or there might be areas where it's not placed. So if you look at realistic dose distribution after the seeds are placed, you actually get a variability from about 3 to 5 millimeters in terms of the depth of penetration of 60 gray. But on an average, when you're looking at D90, you definitely get a good dose distribution of 40 or 50 gray that we are prescribing to.
I think that's a good point. I think that we have to remember as radiation oncologists that, tumors are more susceptible in various phases of their cell cycle. At the late S phase, it's pretty resistant to radiation. When it gets into the G2M phase, it's more sensitive to radiation. And so there is something to be said about having an isotope of radiation kind of lying in wait, getting ready, waiting for that tumor to come to that radio sensitive stage. And that's why I think brachytherapy does have some advantages, as we're talking about some of the dosimetry and whatnot. And again, the repopulation, try to kill cells before they become, start to grow back, before we can get them to the beam. Because obviously with radiation, we're very good with microscopic disease. It doesn't take that much dose to eradicate microscopic disease. We have more gross disease that takes greater dose. And obviously in the retreatment settings, as we're talking about tonight, that becomes a little more problematic. Mike, you were talking a little bit about radiation necrosis, and I guess there's no technology that's not going to have some form of radiation necrosis when we're using radiation in the brain, being it SRS, gamma knife, cyber knife, protons, VMAT, whatever you want to use, or isotopes. And I guess I was always taught to fear, necrosis, but I'm sort of rethinking that, I guess. So a lot of folks with necrosis may not be symptomatic, and those even with symptomatic necrosis seem like they can be managed. Can you maybe bring me through some of that, and sort of what you do, and what we really need to be thinking about in terms of if we do cause necrosis, what we do, and is that necessarily bad?
Yeah, I don't think necessarily it's bad if you can control the patient's symptoms with treatment. And of course, I think, I think Daniel mentioned earlier about the difficulty we have distinguishing recurrent tumor, even with Mets versus necrosis with the modern imaging techniques, MR spectroscopy, blood volume, PET scanning, you name it. I guess the amino acid PET imaging, if it's FDA approved, will help us. But if they go through 2 rounds of steroid medication, with tapers, and they get symptomatic again, you can try the Avastin. The problem, of course, is we know if once you try the Avastin, then you got to wait 6 to 8 weeks to re-op, otherwise, the wound won't heal.
Right.
But I think it's been very effective. Before Avastin came along, we would do 2 cycles of steroid treatment and taper. And if the patient became symptomatic again, we would re-operate on the patient, remove the tissue, assuming they've been previously implanted. We'd take out all the sources and do nothing, just follow them. Post-op scans would look clean. The edema would go down dramatically. Like in the first, I just asked Penny Sneed tonight if she'd ever looked at that in recurrent Mets that were implanted that got radiation necrosis, and she said no, but I can tell you from experience, the reduction in the edema is dramatic. So I think there's no question that the inflammatory component to radiation necrosis is a big component of what causes the problem. That's why surgery is an effective form of therapy for radiation necrosis. So we still have to remember that. Mm-hmm. But I think, I think the biggest change in managing radiation necrosis from treatment has been Avastin, but it has its, negatives as well.
No, absolutely. Well, there's always the bleeding risk and everything else, and just the healing that we know. So we sort of kind of have to go down different pathways and waiting and whatnot. But I do appreciate that. So Daniel, when I'm thinking about some of this stuff, I'm kind of comparing it to sort of prostate, where we do a lot of salvage with radiation with seeds and whatnot. And this is not dissimilar. We sort of max out on our radiation from the external dose because we're transversing normal tissues. Issues are around there, so we do a salvage implant just to try to get that dose conformally. But what I'm thinking more, I know this is a recurrent paper and we're just using the GammaTile without radiation afterwards, but can you foresee a time where you might be able to do like we do with prostate with a boost with radiation seeds in conjunction with beam? And if so, where would you see that kind of headed?
Yes, absolutely. I think, like you said, there's a lot of parallels potentially with prostate and brain brachy. I think the key part is having the perspective, trial data, and GT is running those trials. There's the Gestalt trial for the GBMs, the Rose trial for the brain Mets, but specifically this idea of the brachy boost is being tested on Gestalt, and I think makes a lot of sense potentially for a tumor like GBM, where we have a lot of recurrences that are right in the middle of our field, right? And Dr. McDermott and I were just actually talking about some of the dose escalation trials regarding GBM, and it's been littered with a lot of potentially failed, or I should say failed trials, but there are signals within some of those trials that dose escalation does improve local control in the regions of the high dose field, right? So I think if you can marry that with lower dose to the other normal tissue, higher dose to the target, which brachy gives you, I think there are potential synergies. I mean, it works very well in prostate cancer, as you and I know, and I think there's a lot of potential room for that in aggressive tumors like GBM.
Yeah, no, it's exactly, that's what I've been sort of thinking, because I mean, the isotope half-life is so quick, 9.5 days or so, that, a couple half-lives in, you could really land external beam radiation to get that, especially in the GPMs when you need to sort of get all the infiltrating tumor that we, feel is there. But you're not really competing with radiation, which is still coming. Those become inert by the time a patient's healed up well enough to go. So, I mean, it seems like a perfect marriage to me, as a brachytherapist and loving all things radiation. But, yeah, sort of see where we go. And I guess, maybe as we sort of kind of wind up for tonight, and really for all the panelists, we can all maybe just, give me just a few minutes on what you think. What do you think from a clinical and a research standpoint, what are the future directions of taking care of brain metastases, especially in light of all these different competing, technologies? What do you see how they would fit in? And, can we do better for our patients? I think it really is the question. Are we starting to really kind of bend the curve or bend the needle to some place where we're more effective in taking care of a very dire consequence for the people, or are we still back in, sort of where we were just, 5-10 years ago?
Just to throw a physics perspective on, the future, the question that you just asked, and also ties into what Dr. Kim was mentioning before about marriage of brachytherapy with the external beam, especially for some of these gliomas. One of the big gaps that, we have is the understanding of the biological factors, or the tumor doubling time, or the doubling time, or the repair time, cellular repair time for each of these metastatic lesions for different histologies. So what we have is pretty narrow in terms of what we do have an understanding with the radiobiological modeling with these different kinds of tumors. And so based on just the histology, in this particular paper, we used a tumor doubling time of 31 days based on some clinical data. But there's definitely a lot of scope to understand how that varies between different histologies, and how any seed strength might change or might need to be changed if we have to look at that, depending on how aggressive or how fast the repopulation time is. So definitely an area of development when it comes to modeling these dose distributions, especially if you are going to be adding brachytherapy dose with external beam doses, and try to minimize hotspots.
That's a good question. So I guess right now I think it's sold at what, 3.5 U. So would you anticipate, if you're going to combine, to maybe use a lower activity seed, and potentially if it's a monotherapy using a higher activity seed? Is that?
I mean, there's definitely scope for that kind of a change that can be done.
So some future directions to take a look at some of that. Okay. Dan, what do you think about that? Future directions in brain medicine, what we can do, and what's going on?
Yes, so I think about it in two big buckets. One is patient selection, and the other is synergies with other therapies. So patient selection, some people may call it like personalized or precision medicine, but increasing use of genomic profiling biomarkers so that we can identify patients with metastases or gliomas that might be more radiosensitive or resistant, or things that or tumors that might be more locally aggressive. And that could help guide use of things like GammaTile brachytherapy. Speaking to the earlier point about maybe I call it adaptive brachytherapy, but integrating more advanced PET imaging, which is coming down the line, real-time data. We can adjust radiation delivery or radiation dose. Right, currently it's 60 gray to 5 millimeters. Is that right for everyone? Probably not. Right, like Dr. Orio, as you know, we use a different dose for monotherapy patients and boost patients, right? And now some people are even doing dominant interprostatic lesion boost for prostate cancer, right? With external beam, and also with brachy. Could we do something similar, right? Thinking about which margin is at most risk surgically. And so we can decide that based on changes in tumor biology or responses. And then the second bucket in terms of synergy, right? We know radiation can induce abscopal effects. So there's a lot more work to be doing about combining radiation with immunotherapy. I think there's a lot more work that could be done combining thinking about combining brachytherapy with immune, checkpoint inhibitors. What about targeted therapies, TKIs, BRAF inhibitors, right? Can we provide a more focused, less toxic treatment with other radiosensitizers, CDK inhibitors? And then even things that are traditionally, you know, maybe not just drugs, but Optune, Tumor Treating Fields, right, is a device that has a proven survival benefit. Is there a synergy there that we could use with GammaTile?
Excellent. No, it's a good point. I think we have so many tools, and maybe if we can figure out a way to pair some of them together, we're really start to change, which can be a pretty, scary natural history for a lot of individuals with these tumors and when they metastasize to the brain. Mike, what do you think, from a neurosurgical perspective, where we're going and, sort of the advances in resections and, using some of these adjuvants for treatment?
Yeah, well, I think as far as gliomas are concerned unless I see something dramatic from the Gestalt trial, I think that's going to be a really tough road to make big impact on. But I agree with Daniel. I think one of the advantages, if we look at the comparisons between radiosurgery and medications for brain metastases, one of the advantages of brachy, if you have to operate for a larger met, is you get tissue. So we know the primary tumor is a different molecular profile from the metastasis in the brain, and the recurrent metastasis in the brain has a different profile from the first metastasis. So having tissue is a great advantage for drug sensitivity testing, molecular profiling, receptor targeting. So I think that's where we can really make a difference, because currently we're not doing that, are we? We're just operating and implanting, and then we're basing the treatment on the patient's systemic disease status or medications that are thought to work or demonstrated to work for their systemic disease. But I think we could combine therapies treating both the systemic disease and maybe a different drug if tolerated for the meds.
It's a good point. And when you think about it is, since we're talking about recurrent disease, obviously you're going to field, sort of ablative therapies that came back. Question is, we give enough dose that we missed, did we actually target everything we needed to? Or is it a different player? Is it a different animal? And is it something that we don't know? But I guess, when you're going back through, as we, with big information, sort of everything else that's kind of coming through with the personalization of medicine, could we take that tissue and really try to, change our systemic therapies or even our local therapies, with that.
Yeah, I always remember what Mike Taylor said, the pediatric neurosurgeon, molecular biologist. He said, if you have a trial open, you should get tissue for every recurrent tumor, because we need to study it and we have opportunities there that we're not capturing currently.
It's a great point. Yeah, it's something I think, we sort of forget. It's easy to do gamma knife, cyber knife, IMPT. It's easy to do VMAT, without getting tissue, even though I think the standard still is to, kind of resect and then treat, as necessary. But, there's a lot of times people aren't getting the care they need, right? It's always those barriers of entry too. And you think about how many people, do require post-operative treatments, but they just simply don't get them because of the inconvenience of daily treatments or the cost or what the location of the center may be. It kind of is nice to have this sort of one-stop shopping, right? At least you can do some of the treatments right up front. You have tissue, you have treatment, and, make a lot of convenience for patients. But more importantly, patients are getting the care they require, versus having to wait and hope they can afford to do something which they may not. So there's, I think, a lot of benefit here. Kind of makes me think that, the future can be bright. I think the future, bringing all these tools aboard and, finding different ways to treat, complex disease is going to be extremely beneficial as we move forward. I think we heard today from the panel, there's a lot of research opportunities. There's a lot of things that can be done next, and it's not static. It's exciting because we do have a lot of things to do. There's a lot of papers to be written. There's a lot of things to figure out. With that said, I'd love to thank you all for joining us, me today, and moderating and bringing your insights to this session and allowing me to moderate for you. But again, thank you, and I would like to thank our audience out there watching, and wish us everyone a happy day, and go and do the best we can for our patients. Thank you.